HighBridge, a division of Recorded Books, presents The Vagina Bible, The Vulva and the Vagina, Separating the Myth from the Medicine, by Gunter Md. Read by Gunter Md. Publisher's note: the listener is advised that this book is not intended to be a substitute for an assessment by and advice from an appropriate medical professional or professionals. For every woman who has ever been told, usually by some dude, that she is too wet, too dry, too gross, too loose, too tight, too bloody, or too smelly, this book is for you. Introduction. I have a vagenda for every woman to be empowered with accurate information about the vagina and vulva. One of the core tenets of medicine is informed consent. We doctors provide information about risks and benefits, and then, armed with that information, our patients make choices that work for their bodies. This only works when the information is accurate and unbiased. Finding this kind of data can be challenging, as we have quickly passed through the age of information and seem to be stalled in the age of misinformation. Snake oil and the lure of a quick fix have been around for a long time, and so false, fantastical medical claims are nothing new. However, sorting myth from medicine is getting harder and harder. In addition to social media feeds that constantly display medical messaging of variable quality, there are the demands of a headline-driven news cycle that constantly requires new content, even when it doesn't exist. With women's bodies, there are even more forces of misdirection at work. Pseudoscience and those who peddle it are invested in misinformation, but so is the patriarchy. Obsessions with reproductive tract purity and cleansing date back to a time when a woman's worth was measured by her virginity and how many children she might bear. A vagina and uterus were currency. Playing on these fears awakens something visceral. It's no wonder the words pure, natural, and clean are used so often to market products to women. Members of the media and celebrity influencers tap into these fears with articles about and products to prevent vaginal mayhem, as if the vagina, which evolved to stretch and tear to deliver a baby long before suture material was invented, is somehow so fragile that it is constantly in a state of near catastrophe. Why the Vagina Bible instead of the Vagina and Vulva Bible? Because that is how we collectively talk about the lower reproductive tract, the vagina and vulva. Medically, the vagina is only the inside, but language evolves and words take on new meaning. For example, catfish and text both have additional meanings that I could never have imagined when I was growing up. Gut is from the Old English for the intestinal tract, usually meaning the lower part, from the stomach on down, but not always. It's actually a very imprecise term, yet it has been embraced by the medical community and is even the name of a leading journal dedicated to the study of the alimentary digestive tract, the liver, biliary tree, and pancreas. I have been in medicine for 33 years, and I've been a gynecologist for 24 of them. I've listened to a lot of women, and I know the questions they ask as well as the ones they want to ask but don't quite know how. The Vagina Bible is everything I want women to know about their vulvas and vaginas. It is my answer to every woman who has listened to me pass on information in the office or online and then wondered, how did I not know this? You can read the book in order from front to back or visit specific chapters or even sections as they speak to you. It's all good. I hope over the years many pages will become worn as you go back to double-check what a doctor told you in the office, to research a product that makes wild claims about improving vaginas and vulvas, or help a friend or sexual partner out with an anatomy lesson. Misinforming women about their bodies serves no one, and I'm here to help end it. Gunter Md. Getting started. Chapter 1. The Vulva. No woman has ever benefited by learning less about her body. The vulva is the ultimate multitasker. It is the most important organ for sexual pleasure. It protects the tissues at the vaginal opening. It is built to handle the irritation of urine and feces, and it can deliver a baby and heal as if nothing happened, and do it all again. Oh yeah, and multiple orgasms. The penis and the scrotum have nothing on the vulva. The problem? The vulva is often neglected. A lot of this vulvar neglect is a result of patriarchal society's lack of investment in and fear of female sexual pleasure. When we exclude the vulva from conversations about women's bodies and sexuality, we erase the organ responsible for female orgasm. We also make it harder for women to communicate with their healthcare providers. The most important basic anatomic point of the lower genital tract. The vulva is the outside, where your clothes touch your skin, and the vagina is the inside. The transition zone between the vulva and vagina is called the vestibule. The main structures of the vulva are as follows: mons, labia majora, outer lips, labia minora, inner lips, the glans clitoris, the part of the clitoris that is visible, the clitoral hood, the vestibule, the opening of the urethra, the tube that drains the bladder, the perineum, the area between the vestibule and the anus. We are also going to invite the anus to the vulva's party, even though technically it is part of the gastrointestinal tract and not the reproductive tract. Many vulvar conditions affect the anus, and women often have a hard time getting help for anal concerns. Doctors often hear woman and down there and deflect to the gynecologist. Some women are also interested in information about anal sex, and fecal incontinence can be a consequence of vaginal delivery. The history of clitoral neglect. Going way back, medically speaking, as in Hippocrates, although there is a belief among many academics that Hippocrates wasn't even a real person, male physicians rarely performed pelvic exams on women or even dissected female cadavers, as it was considered inappropriate or insensitive for a man to touch a woman outside of a marital relationship. As there were no female physicians, everything first written about women's bodies in ancient medical textbooks and taught to the first physicians was what women and midwives passed along to men, who in turn interpreted the information as they saw fit. So medicine has been steeped in mansplaining from the start. Most ancient physicians, probably like many other males of the time, were unsure of the role of the clitoris and likely thought it was unimportant. This stands in sharp contrast to the anatomic glory of the penis. In medicine, all body surfaces are assigned a front or back, which we call ventral, front, or dorsal, back. If you look at a person standing straight in a neutral position, arms at the side and palms facing forward, the face, chest, and palms of the hands are on the ventral side, and the back of the hands are dorsal. This convention is applied differently to the penis, because of course it is. The neutral stance for a man, according to the anatomists of old, was a massive, skyward-pointing erection. Except, of course, men don't walk around with constant erections, and so when you look at a man in what most people would consider the resting state, meaning a flaccid penis, the part that faces you is not the front of the penis, but actually the dorsal or back surface, and the undersurface is the ventral. It's not really a small point. It's a wonderful, in a tragicomic kind of way, encapsulation of how society, including medicine, is obsessed with erections, while the clitoris barely registers as a footnote. The clitoris, when it was considered by ancient physicians at all, was believed to be the female version of the penis, but lesser. I'm sorry, but the organ capable of multiple orgasms that only exists for pleasure is not lesser. It is the gold standard. Clitoral neglect wasn't confined to medicine. Think about all those ancient Greek statues with defined scrotum and penises. Although the penises are on the small side because sexuality was apparently at odds with intellectual pursuits, and so a big brain, not a big penis, was the ideal. The vulvas of the time were but mysterious mounds concealed by crossed legs. Around 1000 A.D., Persian and Arab physicians began to take more interest in the clitoris, but given the constraints imposed on male physicians touching a naked woman or even a female cadaver, work was slow. By the end of the 17th century, descriptions of female anatomy, including the clitoris, were quite accurate, anatomically speaking. Some anatomists who made these advancements are memorialized in the names of the structures they accurately described. Gabriele Falloppio, fallopian tubes, also invented the first condom and studied it in a clinical trial, and Caspar Bartholin, Bartholin's glands. By 1844, the anatomist George Ludwig Kobelt published such detailed work that his anatomic descriptions of the clitoris rival those we have today. However, his work was essentially ignored, as was almost everything that had led up to it, likely due to a combination of the expansion of Victorian beliefs, essentially the dangers of female sexuality, and Freud popularizing the false belief that the clitoris produced an immature orgasm. For many years, discussing female sexuality in the doctor's office was taboo, but that oppression is not a failing unique to medicine. In 1938, a Los Angeles teacher, Helen Hullock, was held in contempt of court for daring to show up in pants to testify as a witness and for refusing to change into a dress when the male judge insisted. She was given a 5-day jail sentence. Much of women's health, especially sexual health, was deemed unimportant or irrelevant because that is how women were viewed. Physicians in the 20s and 30s truly believed the vagina was filled with dangerous bacteria. Of course, that idea is absurd, and you don't need a medical degree to reach that conclusion. If the vagina were perpetually in such a state of infectious near catastrophe, women would never have survived, evolutionarily speaking. The narrative of a dirty vagina did, however, fit the societal goal of female oppression. A male-dominated profession, a male-dominated society with little interest in women's experiences and opinions about their own bodies, a penis-centric view of female sexuality, and the belief propagated by Freud's work that the clitoris was unimportant are a lot of obstacles to overcome. The clitoris, being largely internal, is practically also harder to study than the penis. Eventually, anatomic studies using female cadavers to dissect the clitoris were allowed, but it is important to note the limitations of the work. Most cadaveric studies involve a few bodies. 7 is considered a lot. Cadavers are expensive and not readily available. Many cadavers are also older subjects, and clitoral volume reduces after menopause. In one cadaveric study, all subjects were between 70 and 80 years old. The preservation process also distorts the clitoris. Before the advent of MRI, magnetic resonance imaging, it wasn't really possible to know exactly how the clitoris in a living woman was positioned or how it engorges with blood in response to sexual stimulation. Anatomic knowledge has come a long way. While I don't remember each anatomy lesson from medical school and residency, I still have my textbooks. 2 were printed in 1984 and another in 1988. The 2 that are specific for OBGYN are anatomically correct clitoris-wise, but the General Anatomy book, 1984, devoted 3 pages of illustrations, 2 in color, to the penis, with the clitoris relegated to an inset image in an upper outer corner, and the entire structure is the worst shade of puce. It's also called a miniature penis, as if. The clitoris. The clitoris has one purpose: sexual pleasure. It is the only structure in the human body solely designed for pleasure. Structurally, think of the clitoris as an inverted Y, but each side has 2 sets of arms. The very tip of the Y is folded and is the only visible part. This is known as the glans, which is partially covered by the prepuce, clitoral hood. The inverted Y sits on top of the urethra, with the 2 arms draped over either side. Beneath the surface, you find the following: the body, the part of the inverted Y that folds on itself. It is 2 to 4 centimeters in length, connected to the pubic bone with a ligament. The root connects the clitoral body with the crura. The erectile parts of the clitoris converge here. It is very important for sensation because it's very superficial, beneath the skin, right above the urethra. The crura, crus, is the singular, the outer arms of the inverted Y. Some people also describe them as looking like the arms of a wishbone. They are 5 to 9 centimeters in length, and there is 1 on each side, approximately beneath the labia majora. The clitoral, also called vestibular, bulbs, the inside arms of the inverted Y. They are 3 to 7 centimeters in length and are in contact with the outside of the urethra and vagina. Because the clitoris is so intimate with urethra and the lower walls of the vagina, many experts feel a better terminology is a clitoro-urethro-vaginal complex. All parts of the clitoris are involved in sexual sensation, and all parts are erectile. meaning they can engorge with blood, becoming firmer. The glans has the highest concentration of nerves and the least amount of erectile tissue. The body and the crura have the most erectile tissue. The presence of sexually responsive nerves and erectile tissue in all parts of the clitoris likely explains why there are reports of women who were born without a clitoral glans, women who have had surgery that removed their urethra and likely parts of the clitoris that were connected, and women who have endured female genital mutilation, FGM, who are still able to achieve orgasm. This tells us that all of the clitoro-urethro-vaginal complex is capable of sexual sensation. It means there are a lot of sexually responsive areas to explore. This can be for fun, discovering the results from sexually stimulating various areas, sexploration at its best. This can also be in search of orgasm. For some women, the glans clitoris may not be the best pathway to orgasm, so moving sexual stimulation to other areas may help achieve orgasm. This information about the clitoris being so much more than the glans may also give hope to women who have endured injury to their clitoral glands, for example, as a consequence of cancer surgery or FGM, although obviously it does not make up for the loss. The labia and mons. The mons and the two sets of labia, the labia majora and labia minora, exist to enhance sexual pleasure and to protect the vestibule, vaginal opening. The mons is the area of skin and fatty tissue from just above the pubic bone down to the clitoral hood. The fat pad raises the tissue a little, and this may offer a mechanical barrier of sorts. The labia majora are folds of hair-bearing skin and fatty tissue that extend from the mons to just below the vestibule. They are filled with different kinds of glands. They are generally 7 to 12 centimeters in length, but if yours are larger or smaller, that is just fine. The labia minora do not have fat, but they have erectile tissue, so they engorge or swell with sexual stimulation. At the level of the glands, they divide into two folds. The top forms the clitoral hood, prepuce, while the bottom is called the frenulum and sits under the glands. The glans of the clitoris is nestled between these folds, so traction on the labia minora enhances sexual pleasure. The labia minora are filled with specialized nerve endings important for sexual response, especially along their edge. They are capable of distinguishing touch on a very fine scale. The labia minora may or may not protrude beyond the labia majora, and there is no normal size or shape. They can range from less than 1 centimeter in width to 5 centimeters, but wider would not be considered medically abnormal. They may be asymmetric. Think of them as sisters, not twins. The skin of the vulva. Under the microscope, all skin looks like a brick wall. Cells are stacked on top of each other in layers upon multiple layers. The very bottom layer has specialized cells called basal cells. Basal cells produce new skin cells that are pushed up towards the top, like a conveyor belt. The cells develop as they move upwards, producing a protein called keratin that serves as waterproofing and makes the cells tougher so they can resist injury. At the surface, the skin cells release fatty substances that provide protection against trauma and infection, as well as trapping moisture. The cells in the top layer are dead, and they are brushed off with everyday wear and tear or with trauma. A new layer is replaced approximately every 30 days. The mons and labia majora have sweat glands, eccrine glands, that secrete perspiration through pores directly onto the skin. They also have vellus hair, fine peach fuzz-like hair, and pubic hair. Both provide a mechanically protective barrier and trap moisture. As each pubic hair is attached to a nerve ending, tugging or friction on the hair may have a role in sexual stimulation. Inside the hair follicle of each pubic and vellus hair is a sebaceous gland that produces sebum, an oily substance that keeps the skin soft and pliable and contributes to the waterproofing. Pubic hair follicles also have specialized sweat glands called apocrine glands, also found in the armpit, that become active during puberty. They empty a specialized oily sweat with trace amounts of hormones and pheromones onto the hair shaft. Skin bacteria convert the secretions from apocrine sweat glands into odorous compounds, which are responsible for the typical intense apocrine sweat smell. The true function of the apocrine sweat glands is not known, but as they develop and become functional around puberty and secrete pheromones, it is likely they had or still have some role in sexual attraction. The skin of the labia minora has fewer layers and less keratin. These skin changes become more pronounced as you move towards the vaginal opening, vestibule. The labia minora has no hair, but it does have sebaceous glands. Less keratin, thinner skin, and no hair makes the labia minora more vulnerable to trauma and irritants. Secretions from the sebaceous and apocrine glands mix with fatty substances produced by the skin cells and form a layer called the acid mantle, a film on the surface of the skin that helps protect against bacteria, viruses, and other contaminants. The pH of the vulvar skin is around 5.3 to 5.6, so just slightly acidic. Water has a pH of 7.0, which is considered neutral. Melanin. Skin, hair, and the irises of your eyes all get their color from the pigment melanin, which is produced by specialized skin cells called melanocytes in the basal layer. Interestingly, the vulva has more melanocytes than many other body parts, yet it is the same skin tone as almost everywhere else, with the exception of palms and soles, which can be lighter. Medicine still can't explain how your back has fewer melanocytes than your vulva, but they end up the same or a very similar tone. While melanin absorbs and reflects ultraviolet light and provides protection from the sun, melanocytes also respond to biological, physical, and chemical stimuli and are part of the immune system. The vestibule. The junction between the vagina and vulva is the vestibule, and the urethra is located in the vestibule. Technically, the vestibule is external, but the skin is similar to what you would find in the vagina. It's mucosal skin, meaning there is very little keratin and the cells are filled with glycogen, a storage sugar. There is no hair or sebum, so the tissue is primarily protected physically by the labia minora. There are also two sets of specialized glands. The top pair are Skene's glands, which are similar to the prostate in men. Studies show that they secrete tiny amounts of prostate-specific antigen, or PSA. The Bartholin's glands sit at the bottom on either side of the vestibule. They both may contribute a small amount of lubrication. Anal sphincters. The anus has two muscular rings called the internal and the external sphincter. The mucosa of the anus is highly innervated, full of nerves, because the tissue has to distinguish between solid and liquid stool as well as gas, in addition to coordinating the socially appropriate time for emptying. This rich network of nerves is why some people find anal sex very stimulating. It is also why hemorrhoids or fissures, small breaks in the skin, hurt so very much. The internal sphincter is the most important in terms of stool continence. It is responsible for about 80% of fecal continence. Bottom line. The part of your body that touches your underwear is the vulva. Anything inside is the vagina. The vestibule is in between. The clitoris is much larger than what you see and is the only organ that exists entirely for pleasure. There is no normal size for labia minora and labia majora. Labia minora, labia majora, and the mons contribute to both sexual pleasure and protection of the vaginal opening. The pH of the vulvar skin is acidic, between 5.3 and 5.6. Chapter 2. The vagina. The vagina is a fibromuscular tube that connects the vulva with the cervix. I realize this is the least sexy way to describe something that brings so much pleasure. Personally, I'd love to use a different term, as vagina means sheath in Latin, and I hate having female anatomy defined in terms of how it fits with a penis. Medically, the vagina starts at the hymen, so just inside the vestibule. Why do we even have a hymen? Evolutionary biologists have not been able to answer this question. Some experts have postulated that a hymen may once have served to prove to a male mate that he wouldn't be raising another man's child, but there are several reasons why this seems improbable and ridiculously patriarchal. The hymen can tear from physical activity, and approximately 50% of teens who report sexual activity still have an intact hymen, meaning it is a highly unreliable virginity indicator. This preserving purity theory also implies that, evolutionarily speaking, only the first child has value. But for most of human history, 30 to 50% of newborns did not survive their first year. It makes no sense to invest a supposedly precious biological resource for a sexual encounter that may not provide a child who lives, or even produce a child at all. Another proposed theory is that the hymen evolved to make first sex painful, so women would only have sex with a bonded male partner. However, it's pretty clear that for the majority of women, their sexual debut is not painful enough that they're going to hold out for some hypothetical Mr. Right. If it hurt that much, we wouldn't have so many teen pregnancies. Also, if the evolutionary goal was to keep the first sex disappointing enough that women wouldn't bother to look elsewhere and hence stay with their first man, it seems counterproductive to have such an amazing organ as the clitoris be fully functional early in the reproductive years. My theory is the hymen was at one point in human history a physical barrier for protection. Before puberty, the mucosa, skin, of the vagina is very sensitive to irritants. If a prepubertal girl gets even a small amount of dirt in her vagina, the dirt can cause a profuse inflammatory reaction. Estrogen, fat pads in the mons, and labia majora, pubic hair, and labia minora, essentially all of the protective mechanisms for the lower vagina, don't develop until puberty. So I believe the hymen was a pre-puberty physical barrier against dirt and debris. As we evolved and began to walk upright, physically taking the vaginal opening farther away from the dirt, the need for a physical barrier for the lower vagina lessened, and evolution became less invested in a rigid, physically protective hymen. This would explain why we now have so many variations in hymen shape. It is simply no longer biologically important. In a fetus, the vagina starts as a solid tube. The cells from the inside gradually disappear. This proceeds from top, the cervix, to bottom. Any remnants that remain at the lower part of the vagina are the hymen, which can be a ring, crescent-shaped, have holes, or even be absent altogether. Sometimes larger portions of cells are left behind, which can lead to a band of vaginal tissue that runs horizontally or vertically. This band is called a septum. A septum can be flimsy and break easily with a tampon or penetration during sex, but it can also be very thick. Rarely it can even obstruct the vagina. The presence of a septum should be considered for any teen who has not had a period by the age of 16, any woman who is unable to insert a tampon, fingers, a penis, or have a speculum exam due to pain, and any woman who has a feeling of an obstruction with vaginal penetration. Vagina, the basics. The vagina is lined with specialized skin called mucosa. The mucosa is arranged in accordion-like folds or ridges called rugae. Some women may perceive these as bumps or roughness. The best visual for rugae is a king-size fitted sheet on a queen-sized bed. The mucosa sits atop a layer of smooth muscle, which is technically the outer wall of the vagina. Smooth muscle is a type of muscle not under voluntary control. Your gut is also made of smooth muscle. While not all the functions of the vaginal smooth muscle are well known, it is believed it moves blood and vaginal discharge towards the vaginal opening. If the muscle contractions become uncoordinated or spasm excessively, this can cause pain. There is data that suggests that some women who have painful periods have more spasms or uncoordinated activity of their vaginal smooth muscle. The rugae and smooth muscle allow the vagina to be collapsed at rest with the walls touching, keeping air out, and then to stretch for penetration or for vaginal delivery. Everyone, the patriarchy, seems very impressed with the ability of a penis to grow, but the few centimeters of change that a penis can muster up pales in comparison with the vagina's ability to stretch. The vaginal smooth muscle is surrounded by a network of blood vessels. The rich blood flow is one of the reasons the vagina typically heals well after injury. Vaginal length can vary significantly. The back wall, closer to the rectum, is longer and can range from 5.1 to 14.4 centimeters, and the front wall ranges from 4.4 to 8.4 centimeters. Your body size and shape are not predictive of your vaginal length. The vagina gets wider as you move from the vaginal opening towards the cervix. The pelvic floor. The pelvic floor muscles, PFM, are two layers of muscles that wrap around the vagina and the vaginal opening. These muscles provide structural support for organs, assist with continence, bladder and bowel, contract during orgasm, and also help with stability of your core and posture. On average, the pelvic...
Sample complete. Ready to continue?